Thank you, Paulina. You are now live on YouTube.
Thank you, Karen. Chair, if you'd like to start the meeting.
Sure. Thank you, Paulina. Good evening, everybody. Welcome to the House Scrutiny Committee. I would like to start by welcoming those members of the public and press who are watching the live stream of this meeting through the Council's YouTube page. Due to government guidance on social distancing, this meeting is taking place remotely in accordance with current legislation, which makes provision for remote attendance at and remote access to council meetings. The meeting is also following Peterborough City Council's virtual meeting protocol. In order for this meeting to run smoothly, I ask that members and participants keep your video camera switched on with your microphone muted, except when you are invited to speak. If you wish to speak, then please raise the virtual hand, which is blue and is located at the bottom of the participants section. Or if you have a newer version of Zoom, it will be in the reactions section and is now yellow. Whichever version you are using, please ensure you use the raised hand function to indicate that you wish to speak. I and the Democratic Services team will keep an eye on the participants list to see who wishes to speak. Please be patient if you are not invited to speak as soon as you have raised your hand, as there may be other people wishing to speak before you. The Democratic Services team will be monitoring the participants list to see if anybody has dropped out of the meeting, and will try and contact you to provide assistance to rejoin the meeting if this should happen. If we run into technical problems, I ask for your patience. Should this occur, an adjournment of the meeting will be declared while the fault is addressed, and the public broadcast will be paused. If it is not possible, the meeting will be adjourned until such a time as it can be reconvened. Finally, I would remind members that all virtual meetings are recorded. Before we move on to the first item on the agenda, I will be taking a roll call of all Scrutiny Committee members to establish their presence. When your name is called out, please unmute the microphone and confirm that you are in attendance. Thank you. Councillor Ali.
Present. Good evening, everyone.
Good evening. Councillor Barkham.
Present.
Councillor Burbage.
Present, thank you.
Councillor Hemmarge. Councillor Hemmarge.
Good evening. Present, good evening.
Councillor Kayam.
Present.
Councillor Rush.
Present.
Councillor Sanford.
Yeah, thank you.
Councillor Simons.
Yeah, present.
Councillor Warren.
Good evening and present.
Parish Councillor Co-opted Member June Bull.
Present, Madam Chairman.
And we also have Susan Mahmood, who is also in attendance representing Health Watch.
Good evening, present.
Thank you, Susan. Also in attendance is Dr. Liz Robin, who will support the committee as lead officer, and Paulina Ford as supporting Democratic Services officer. So on to item number 1, apologies for absence. Are there any apologies, Paulina?
No, Chair, not for this evening's meeting. No apologies.
Good, good. Agenda item number 2, declarations of interest and whipping declarations. Are there any members, committee members, who have any declarations of interest or whipping declarations to declare?
Myself, Councillor Hemmarge. I'm a employee of North West Anglia Foundation Trust, so I won't be taking part in the discussions on item number 6. Thank you.
Okay, thank you. And we'll make sure that at the start of that evening we put you into the waiting room and then bring you back for the next item. On to agenda item number 3, minutes of the House Scrutiny Committee meeting held on the 12th of January 2021. We are being asked to approve the minutes as set out in the agenda as a correct record. Can I ask if any member who does not agree that the minutes are a true record of the meeting, click their raise hand function on your screen now. Okay, no hands are up, so we'll take it that the minutes have been agreed. Agenda item number 4 is call-in of any cabinet member or key officer decisions. Pauline, do we have any call-ins at all?
Thank you, Chair. No, we have no call-ins for this evening's meeting.
Thank you. Okay, so we're on to agenda item number 5. So Paulina, if you want to put Councillor Hemraj into the waiting room, and I would like to welcome the following officers who are in attendance to present this report. In order of each area, we have Caroline Walker, Athar Yassin, Stacey Coburn of the North West Anglia Foundation Trust, Jessica Bowden, Dr. Andrew Anderson, Vazir Ahmed, and Joanne Walker of the CPCCG. So welcome to all of you. There's quite a lot of you. I wasn't going to go through every single title, as by now we're at the end of the year and we all know who you are. So who's going to present the report to begin with? Is that Caroline or Jess?
I believe Jess is going to kick off and I'm going to help, but we ideally want the clinical leads to take you through the vision for the new centre that we're planning.
Sure, no problem. You start with whoever you want to start with.
Thanks very much. I'll kick off. So the paper in front of you answers some questions that you've posed us in the past around a number of concerns and issues that you're interested in finding out further about. We've answered some of those questions in the paper, but what we've also done is set out some more around the actual patient pathway and how the oversight board, which is monitoring the progress around the issues that you've raised, is working. What we've done is set out the actual pathway of how it worked. We also set out an update on the estates work, which Stacey Coburn can update on. I think primarily what we'd like to do is, we've got colleagues here from the Trust who are going to be working in the UTC, and also Dr. Andrew Anderson, who works on out of hours and 111, really to explain how what it would be like for patients. I think we've talked quite a lot about the operational elements and around other issues such as that, but we'd really like to take questions on what it would be like for patients. We, since we last met, we agreed that we'd be delaying the start of the new service until the 30th of June. That was in part in response to some of the concerns that patients and yourselves had around doing this during the middle of the peak of the COVID pandemic, and partly for logistical reasons. So those are the current plans as it stands. I'm happy to take questions unless, Caroline, you want to add anything in particular before we... Can
I just add, if that's okay, to what Jess has said? Hopefully the paper's comprehensive. We wanted to give you a complete update on where we'd got to answering the questions that had previously been raised, and giving reconsideration to the detail that we've given you. We've given you lots of detail, so I'll apologise for that, but we wanted to make sure you had everything at your disposal that we had when we were taking our decisions. But more than anything today, we wanted to reassure you of progress, that we're ready for this to happen on time, and then allow our clinicians and clinical leads to take you through what this means for patients and the clinical care that we plan to deliver when we co-locate.
Sure, no problem. So are you planning on splitting this then? Are you saying that they've got a piece to present as well, or?
I wonder if Athar might want to just step in here, maybe to talk a bit about the vision and what it would be like for patients at the end of June and what will happen. So I think what's been difficult is we've talked quite a lot about the operational side, but we haven't talked about the reality if you're a patient and what happens to you if you're not feeling well. Is that okay if I bring in Athar to talk about that?
Yeah, what I was going to say is if you all say your bit, and then we'll ask questions, and then we've all got the full picture. So yeah, that's fine. Go ahead, Alpha.
Can you all hear me?
Yes, we can hear you.
Thank you very much for giving us the opportunity to come in front of you and talk about the vision for our UTC. So this is me as the clinical lead for emergency department at Peterborough City Hospital, as a clinician, as a person who will be a service user. So one of the biggest thing that we have had previously a difficulty with, patients have got access. There are multiple access points for patients. If I'm ill, where do I go? Do I ring NHS 111? Do I go to UTC? Do I go to emergency department? Where do I go? So our vision is, patient, if they are ill, you ring NHS 111. NHS 111 will essentially triage patients. So they'll triage patients and they will advise accordingly, because the patients will be triaged by clinicians based on their triage, whether the patient needs management at home, whether they need an appointment with the GP, they'll be able to sort that out. Now, if the patient needs to be seen by a clinician, the NHS 111 will essentially book people in an appointment to come to UTC, minimizing patients attending emergency departments, waiting for longer times, and then whether they have to move from one service to another. Currently, if you're a service user, you go to a city care centre, you might get your problem sorted out, but you might have to move across to come to Peterborough City Hospital to be seen by either emergency department or by other inpatient specialties. Once we have a co-located UTC, it is all at one place. So you will come to this UTC, to our emergency centre, and as a patient, your worry is, I'm unwell, and leave it to the clinicians to decide where you need to be treated. And as clinicians, we will decide whether you need to be treated within the UTC. We'll do that by appropriate clinicians. If you need to be treated by emergency physicians, you'll be seen and managed by emergency physicians. If you need to be managed by inpatient specialties, we will do that, because everything is on one site. So it prevents people from going from traveling from the city care centre across to Peterborough City Hospital, minimizing delays. So essentially, we will look after your needs. Essentially, you present to the hospital and we will look after and deliver the care by whichever clinician needs to be. And that will be the clinician's decision. So they will manage your expectations in the area which would be right for the patients. So the vision is, you'll be seen by the right clinician at the right time within the right area. So that's our vision to deliver the care.
Okay. Is there anybody else? Is that you finished your presentation, Abba?
Yes, I'm happy to take any questions.
Thanks.
Is Stacey?
Has come in now. Sorry.
No, that's fine. Go on.
Yeah, hi, can you hear me? I'm just going to initially say what my role is. I'm the Urgent Emergency Care STP lead for Cambridge and Peterborough, and I've been that for the last few years now. And I work along with Andrew Anderson, who's the Urgent Emergency Care lead for the CCG. I think in Cambridgeshire, we did move our place from Chesterton and co-located the whole of the UTC to one place, which is basically within the hospital. And at that time, we went to the Health Scrutiny Committee, and what we debated was the reason what Atta has just mentioned. I'm not going to repeat everything, is that the urgent emergency care, especially out of hours, is fragmented. And the aim of co-locating emergency care and urgent care was so there's seamless movement of patients across services and which they can be managed easily. Right now, there's quite a lot of confusion where the patients attend and where they need to be seen. So this is part of the bigger picture of our plan in Cambridge and Peterborough to make sure that we make our urgent care system one of the best urgent care systems in the country, because we are being noticed for the work we have done through the whole of the patch. And that includes some really innovative work which we recently started at 111, where we have put emergency physicians who would take calls if a patient was asked to go to a place. That call is now dropped between the hours of 10 and 8 on our peak hours into an emergency physician, who would then have a video consultation and make a decision whether you need to come today. Can you be brought in for a booked appointment tomorrow? Can we book you in somewhere else? So I think what we are trying to do here is provide the best care available for Peterborough citizens as well as Cambridge citizens, but there is consistency across the whole patch. So in short, what we are trying to do is be as effective and responsive to your needs when you want it. Thank you. Andrew?
I've got nothing to add, really. I think I just would welcome questions from folks. I can talk about 111 first and how the future lies with patients' way of accessing urgent healthcare will be through the telephone and online assessments. And then following those telephone assessments or online assessments, people will be able to book a specific timed appointment at a service that best meets their needs. I think from a triage point of view, and I do a lot of that in out of hours and in the day job here, triage is an imprecise science sometimes, and sometimes you do get people in the wrong service. So really, this is, for me, it's as much as a safety net sometimes. If we book people into the wrong service, you can easily move them between the service, because when you see people face to face, sometimes you find, actually, no, these people need to be in this service. And this allows us to move people between the services. So that's the biggest advantage of this. It's looking at what the future holds. The future, certainly the national push is for telephone first. 111 first is the national ask of us all. And it's how we make the receiving service for that. And there'll be many of them, including same-day emergency care services. It's no longer just going to be ED. There's going to be lots of other more specialist services that will receive patients directly. It's how we book them into those services. And if they do get into that service, but actually the service next door actually probably ought to be dealing with this. Once you see them, you can easily move them into that service. So I think that's why I think we need to be doing this.
Is that everybody, Jess? Yeah. Okay, so if we go on to questions then, we have Councillor Bull.
Thank you, Madam Chairman. My question relates to page 14, 3.2 para 3. I'm intrigued to know what is meant by, where appropriate, integrate with emergency department and across services. For example, if someone presents on the day with multiple issues and has various underlying conditions which their own GP knows about, and is fully aware of course, but the UTC IT systems may not be fully updated, who takes the overriding decision of their urgent treatment and the appropriate care pathway across services? For example, is it ultimately the patient's GP? Is it the UTC consultant, or is it the GP out of office, out of hours service that makes that judgment call? Thank you.
Can I come in on that? So essentially, when a patient presents to UTC, he or she, they will be assessed by a clinician in UTC. And if they have complex health needs, which require other clinician involvement, so that can be done within the UTC and with the involvement of the other specialities. Because when we say, when Andrew talked about SDEC, so SDEC is same-day emergency care, which involves a medical assessment unit, a surgical assessment unit, which will have urology, the ENT, we've got orthopedics on site. So depending on what the patient's needs are, we will involve the inpatient specialty teams to make a comprehensive decision about the patient's care. But whilst the patient is in UTC, it will be, the patient will stay under the care of the UTC till they are discharged from UTC. Now, if they need to come in, they will be admitted from UTC to an inpatient area, whether that's a medical area or a surgical area. But if we feel we are able to discharge this patient, then we would discharge the patient back to the care of their general practitioner. Does that answer the question?
Yes, it does. Ultimately, you're saying it's the UTC clinician who has the judgment call. I understand that. But the care pathway, who has the ownership of that was the crux of my question.
So the pathway is emergency and urgent care pathway. So when the patient presents to our emergency floor, they initially get assessed by, so how our clinical pathway works is when you arrive as a patient, if you arrive you arrive to our emergency center, the first thing at the moment and for the foreseeable future, you will be assessed for COVID symptoms. So after that, once you're booked in, you will be assessed. You will have an initial assessment by a senior nurse. So once the nurse assesses you, they will assess your clinical needs. Now, depending on your clinical needs, they will put you through to one of the pathways, whether you need to go to be seen in UTC, then in UTC, you'll be assessed by the practitioners or the GPs. Now, if your need requires an emergency department intervention, you'll be then seen, but you'll be then streamed through to emergency department where your care will be taken over by the emergency team. While as if you are known to have complex medical problems, where you are known to, for example, a medical consultant, and this problem is as a result of a complication of that problem, then we will stream you across to medical assessment unit or ambulatory care unit, where you will be directly seen by a medical team, rather than going through another step of seeing an emergency physician, they asking the medical team to assess you. So we will directly put you into those pathways. So essentially minimizing the contact with multiple medical professionals. So does that answer the question?
It certainly does. Thank you very much.
Councillor Kayhan.
Thank you very much. Good evening, everybody, and thank you very much for that very detailed overview of relocation of the UTC to PCH. And I'd like to first of all thank you for all the hard work that you've all been undergoing during the pandemic. So that definitely doesn't go amiss. My question is regarding the aspects surrounding walk-in bookings that was given in the report. So we were given a bit of an overview that patients that will be able to have an appointment in the UTC when they walk in on the day entails for an appointment for them to be booked in so that they don't have to wait. Now, my assumption of that, and please correct me if I'm wrong, is if a patient goes in the morning at around 10 o'clock and is given an appointment in the afternoon, would they be expected to go away and then come back? Because it just seems to be a bit of an arduous process. And obviously, Dr. Anderson, you know that accessibility with GP appointments at this moment in time is something that's quite critical. So I was just wondering as to what that actually meant, and if patients will be seen earlier or will they be asked to come back at a later time, and what purpose that seeks to achieve if that is the case. Thank you.
Can I answer that? Or Andrew?
Yes.
So essentially what we are planning to do is if your need is that you get a disposition that you need to be seen now, then within an hour you will be seen in UTC directly within an hour, if that is what your disposition is. Now, if you can wait to be seen and essentially you can wait for 2-3 hours, then yes, we would like, because our aim is to minimize patients waiting in our waiting room. Because of the social distancing, we don't want patients to be waiting in our waiting room. And essentially the whole idea is, if you had rung NHS 111, we would have sorted the issue either by what Andrew earlier said, by telephonic consultation, video consultation, or given you the right time and giving you an appointment time so that you didn't have to make 2 journeys to the hospital. So what we want patients to do is minimize the travel to hospital. So if you have a health need, please ring so that we minimize your travel to Peterborough Hospital, or for that matter, to the hospital. Because if you had done that, you would get an appointment, and we will aim to see every patient who is booked into our UTC within their arrival time. That is what our aim is. But we can only do that if we can book those patients appropriately. Because if we end up having patients sitting in our UTC waiting room, we would struggle to maintain the social distancing, as with every other services, because it is not easy to maintain the social distancing. So that's the whole point, is so that patients ring NHS 111, because they might not need to come to hospital at all. And Andrew might be able to solve the problem before them coming into the hospital via video consultation. Andrew, do you want to come on that?
Please, yeah. So I think we have to look at what are the current processes and what are the processes that we're proposing. So at the moment, if you go to the front door, you'll be booked in and you'll sit in the waiting room for however long it takes before the department have got time to see you, crowded with a lot of other people reading your copy of War and Peace. And I've seen people taking their books into ED to read. What we're proposing is, yes, you can come in, you will be assessed. If your need is fairly urgent, clearly you will be assessed fairly swiftly. You'll be seen fairly quickly. If you've had something that's been going on for a week and actually you could be seen in a couple of hours, you'll be offered an appointment. Now, people will be encouraged to go off and do something else, do their shopping and come back at whatever time it is, 2 o'clock. If they want to sit and wait, which is what they've done before, then fine. But I think, that's for people to choose. But I think the thing is, we would discourage that. And what we would try and encourage people to say, well, perhaps next time if you rang 111 first, we will do the assessment. We will get you an appointment in ED. Then you won't need to come to get that appointment. You'll turn up at your time and hopefully be seen roughly within that time. Moving away from ED's waiting room is, as I say to go, ED's waiting room is not those seats in front of the desk anymore. ED's waiting room is everybody's front room. And that's what we need to try and think about this, is that the way to access ED at the moment is you can only walk through the front door, but actually we're looking at a different way of accessing urgent healthcare, trying to do it in a booked way. If we can get you on the phone, we hopefully will be able to get you into a service that better meets your needs. That might be GP out of hours, UTC, it might be full ED, it might be one of the same day emergency care services. One of my things is an acutely painful red eye, non-traumatic, loss of visual acuity. Do they need to see a GP or ED? Or actually most of those patients will end up in front of an ophthalmic on-call team that day, because most of us feel a bit unsure about managing those sorts of things. So wouldn't it be really good if you could book those directly into the expert who actually knows what to do with that patient, rather than these multiple different contacts throughout the day, and by tea time you might get to see the real person who knows what to do. So that's what we're trying to think. We're confident, we can do this, and if we can get people on the phone and schedule stuff, ED won't be so crowded. And my holy grail in all this is you'll turn up at ED at 4 o'clock, you'll be seen at 4 and out the door by past, and you won't be sitting there making the place look untidy. But that'll take a little while, I think, to get that change in people's behaviour. None of us would turn up at the airport for a flight to Barbados and expect to get on the next plane. It's not going to happen.
Yeah, absolutely. Well, thank you very much for those answers. I guess my concerns were rather, obviously, given the surface area of the hospital and the distance that the frail, the elderly, the less able-bodied have to get to the UTC, to then be told that they're going to have an appointment later. So I think it would be pertinent to stress the messaging of ringing up NHS 111 rather than just presenting, if it can be avoidable and if that can be looked at going forwards. But no, thank you for answering those questions.
I hope we'll have leaflets, Sharina, in languages explaining what we've done today. And actually, when you're next time, please ring, and obviously lots of different languages as well, because we do have a. I think 111 is used differently with different language groups in the city.
Thank you.
Thank you, Andrew. Badia?
Yeah.
Did you want to?
Can I just come in? I think a couple of reassurances. Can you hear me?
Yes, we can hear you.
Sorry. I think I just want to reassure. One of the things is that every UTC in the country has got some specifications, and we cannot contravene that specification. And one of that is that if you come to the UTC and if you're planning to book you in, it has to be within 2 hours. So we are not, the only time you're going to be sent away and brought back the next day is if you're going to be, for example, we're going to book you in the specialist clinic. But if it is the UTC, you're coming back to the UTC, there is some national specifications we have to follow, and that is 2 hours. And the second question about the messaging, there is a national campaign regarding NHS 111. We have run a local campaign in Peterborough and in Cambridgeshire about how people should call NHS 111. We have been very mindful of the fact that we need to close all the loops. That means you explained about the GPs not having enough appointment slots, but now NHS 111 can book you into GP appointment slot, and each of the GP practices 1 in 500 patients, there should be 1 urgent care slot. So, and in fact, we are doing really well at booking in people. So I think we have a very good system. We have one provider who's very responsive, and I think we have some really good GPs in both sides of the patch who really work very hard for the patients. So I really want to reassure you, I think it's just about closing all the loops and making sure urgent patients are seen in urgent care center, emergency patients are seen in emergency departments, prevent crowding, no infections.
Yeah, thank you. I certainly know that it's working because all my slots were booked up today by NHS 111. So yeah, but thank you so much.
Okay, next question, Susan Mahmood.
Thank you. The part that seems to be missing, and I do appreciate 111 and I think it's a very good system, is the role of the GP during surgery hours. Because whilst I would always ring 111 if it were out of surgery hours, I much prefer to speak to the GP who knows my husband, who will make a decision, who will then send one of the jet team, who will then decide whether or not he needs to be admitted. Am I supposed to be doing that, or am I supposed now to ignore the GP and go straight to 111?
Hi, Susan, it's Andrew.
Hi.
So no, during the day, most patients are still ringing their GP, and we would encourage that. They're the patients who are often best placed to use it. We do get our patients here out in Whittlesea ringing 111 during the day. 111 have the ability to book them into us. I think the issue as that's been alluded to, I think access to general practice is variable, and patients do have difficulty getting through. I don't want to go into too much detail on that, but I can show you my slots today, Shabina. They're all empty. 111 hasn't used any of them. So, you know, it's interesting, but they are there. 111 can use it. I'm hopefully going to see a few more 111s in there as we go forward. But no, ring your GP during the day. You can still ring 111, and 111 will still book you into my ring back list, and we will ring you back. But yeah, mostly during the day, please ring your GP.
Thank you.
But out of hours, it's definitely 111.
Thank you.
Councillor Sanford.
Yes, thank you. It's really interesting to hear how it's going to work, and I am partially reassured. Just got a question though. There's an awful lot of reliance seems to be put on NHS 111 service. People who would have normally gone to the urgent care centre are going to ring NHS 111. People who would normally have gone to accident and emergency are going to ring NHS 111. So can we be assured that that service is going to have a sufficient number of call handlers? Because one of the issues that we've dealt with previously at this committee is GP surgeries that require people to call at 8 o'clock in the morning and have to join a really long queue. So I think this system is going to work if the NHS 111 service is sort of adequately resourced. But if we get into a situation where people are going to have to wait 20 minutes to be able to get through, then I think you are then going to have loads of people just turning up, which seems to sort of defeat the purpose of what you're actually proposing.
I think you're absolutely right. We are aware that 111 will need to increase its capacity, and we are going to constantly keep our eye on that. There's a very strict KPI for our key performance indicator for our 111 service. You know, they have to answer the phone in a swift manner, and we're doing very well in Cambridge and Peterborough in that regard. In fact, we're one of the better ones in the country. You can go to 111 MDS, Minimum Data Services, public available data. You can see how well the services are performing. And you know, we answer the phone very quickly in CMP and get the settlement properly. But you're quite right. If 111 first takes off, the call volumes will go up, and you know, we will be constantly monitoring that and ensuring that we're getting sufficient staff trained and in the call centre, which, as you all know, is situated in Peterborough, to deal with the number of calls. And that to me will be a success. You know, if we get more people ringing, with the bigger more people in the call centre dealing with these calls, and then we can get them in the right place. To me, that's what success looks like.
Thank you, Andrew. Jessica.
Hi, thanks. Yeah, I was just going to add to what Andrew said. So we have invested quite heavily into 111 over the last few years. I'm desperately looking for the figures, but on the answer within 30 seconds, we do very well. And that's monitored every single day. So just to reassure you that we don't expect, and it's very, very rare for anybody to be waiting more than a few minutes to be responded to in 111. So we will absolutely make sure that remains the case.
Thank you. Bazia, did you have something?
Yeah, I'm just following on from Jess and Andrew. One of the things was that when the National NHS 111 campaign got off around November, there was an investment to all 111 providers in the country to increase.
I think your sound's going a bit. Could you turn your video off?
Can you hear me or not?
We can hear you, but it's just very intermittent. If you can turn your camera off, it might make it a bit better.
Yeah. Yeah. Can you hear me now?
Yeah. If you turn your video,
I'm sorry. Do you want to go ahead? I think Jess and Andrew are done, so I'll leave it.
Okay, all right, no problem. On to the next question, then it's June. Councillor Bull.
Thank you very much. I'm going to turn to transport now on pages 17 and 18. My first question is, why doesn't the new orbital bus operate on a Sunday? And I appreciate the snapshot survey. was undertaken on Friday, the 29th of January, but it was only for 3.5 hours, so not that representative of public transport. Plus the orbital bus was only introduced after the survey on the 1st of March. So what other surveys are planned, factored in to accommodate the relocation before the 30th of June? And I also note the recommendations on page 40 from the Atkins review of 2019, where they look at recommending annual staff travel surveys, annual parking surveys, and annual transport steering group meetings. And I appreciate the pandemic hit us on the 23rd of March last year, but if you're looking at samples of public transport prior to a major orbital bus being introduced, and the fact that we're now in pandemic and people are being asked to travel by car where possible independently, so they're not coming into contact with any other person, it seems to me that that survey isn't at all representative, and we're looking at public transport here, particularly if you're using the 111 service and they say, okay, we've taken into account all the medical conditions that you've relayed, and we would like you to go to the out of office, the out of hours GP service, or indeed ED, the emergency department. You need to have public transport available for those people who don't have their own cars. So I'm just wondering, where does all that fit with going live on the 30th of June? Thank you.
Perhaps I can take that.
Okay.
I'm not sure I can answer all of those questions. What I can commit to is to keep doing the surveys of where our attendance has come from. I think what I've done in the paper, what the team have done in the paper, is explain that there's adequate car parking on site now. We've done lots to digitalise lots of our appointments, so there are over 7,000 appointments not coming to site anymore. So car parking on site isn't an issue. And the surveys that we've done, and the surveys that we did on the City Care Centre when we did the big conversation with people, did show that the vast majority of people weren't attending on public transport for these out of hours, largely out of hours consultations, or not through the main bit of the day consultations. So I'm happy to commit to doing another survey for a different period. The Atkins report was for a pre-pandemic period. Lots has changed since then. Lots of it is valid in our aspiration to get as many people using public transport and to reduce our carbon footprint. But for these services and these out of hours services, I think the vast majority of our patients are coming in their own cars, or being brought by other people in their own cars, in their cars. But I'm happy for us to commit to keep doing these things and keep it under review. But I think I've given a comprehensive account here of the position as it stands now. We'll need to keep a watching brief on it. But there's plenty of car parking on the site now, and congestion isn't something we're worrying ourselves with in a world post-pandemic as it stands.
Thank you, Caroline. And I think that really is what we would like, is that going forward, for there to be a continual sort of snapshot of exactly what's happening, because we all appreciate, all committee members appreciate that things are changing at the moment, obviously with the pandemic. And if we come out of lockdown and things start to move forward more into sort of a normal situation, then it would be good to sort of continue seeing those snapshots going forward, just to keep an idea of exactly whether everybody's coming by car or whether they start to use the transport a lot more. Councillor Sanford.
Yeah, I'm glad that June moved us on to the transport thing, because as I've indicated at previous meetings, it's an area I've certainly got a lot of concern about. If you look at the sort of Atkins report in the Green Travel Plan, if you look at page 30, it's quite disturbing figures are quoted in there. It says, since 2016, there's been a 13% increase in car usage, and there's been a large reduction in use of sustainable transport. So despite these aspirations that the Trust seems to have, they seem to be going in entirely the wrong direction. I think we've June has mentioned that there are, some concerns about the SNAP survey that was done on the 29th of January. It is true that the current advice during the pandemic is that people should only use public transport where it's absolutely required. But the government advice is also people should be walking and cycling where they can. Your survey on the 29th of January actually shows there wasn't, not only was there not a single person using public transport, wasn't a single person walking or a single person cycling. So I think, I think this performance needs to improve. So could I actually request that that during the next year of the council that we have some sort of further review of the green travel plan, because I think it's legitimate possibly to say you've only been operating it for a short period, so it's maybe too soon to actually have an impact. But I think if we could have a review, say in 6 months' time, then we could actually form a view as to whether these aspirations are actually being translated into achieving practical changes.
I'm happy to commit to something in the longer term. Obviously, we did that travel study and the commitment to reducing travel to site to avoid congestion and to reduce our carbon footprint in a world pre-pandemic. Since then, there's hundreds of people every day not coming to site who are working remotely and working from home and working digitally. So there's a complete mix of different things affecting how we will have achieved that reduction in people coming to site, and we have put more car parking spaces in as well. So it's something that we're committed to and still need to work on. But I think we'll have delivered it in many different ways to what we originally intended, and fast track some transformation that we really didn't think would happen this quick to get people working agilely at home digitally and to bring such large amounts of patients to not have face-to-face consultations in a way that we've been wanting to do for some time. So it's a whole combination of those things that have significantly affected travel to the campus, and I know it will increase once lockdown changes, but hopefully it won't increase to anything like it was previously.
Yeah, okay, so absolutely take all that as true, but so can we say that sometime within the next 12 months, can we have a further report on how progress is being made with the green travel plan?
I'm happy to commit to that, yeah.
Thank you, Caroline. I'm sure Paulina would have captured that as one of the actions. So, okay, Andrew, you've got your hand up. Is there something you wanted to say?
Yeah, just I suppose with urgent care, people are often unwell, and I think it's a different cohort of people to people coming to the hospital for the routine outpatient clinics who are basically well. These are people who are actually ringing on a weekend, on an evening, who actually are quite sick, some of them, and they are certainly not going to get on their bike or come in public transport. And I think usually they will be by car. And that's why when you do the surveys of urgent care, you've got a subset of patients who are actually unwell, so they will choose an appropriate method to get to their place of care. So I think I don't think we're going to push sick people onto those sort of things. I can see it would work for routine outpatient appointments, and I do get that. But I think for the clients that we're dealing with are people who are feeling unwell, and so it wouldn't be medically correct or right to try and push them onto a public transport or a bike thing. I don't think we're saying that, and I think, yes, let's do the surveys, but I think the surveys, certainly of urgent care access, will remain firmly fixed to car for some time to come, because I can't see those ill people using another way to get to come for their healthcare needs, frankly.
Thank you, Andrew. I think, I guess from my point of view, you use a car or you use a taxi, but there might be some people that have no alternative but to perhaps use public transport, even if they're feeling unwell. So we just, you know, as a committee, we have to look at every eventuality and not discount them. So, you know, that I think is where Councillor Sanford's coming from. So we know there's not going to be a huge number, but we still have to think about those people that don't have any other option.
So could I just come back on one very quick point? I think, you know, I don't want to go into the detail of the green travel plan, but it does deal with not just people attending for sort of urgent care, it deals with all people attending the hospital. And I think it also deals with employees. And I think, you know, that's also an important thing as well.
Yeah.
So it might be what we need to do is to split these people out, and the employees and the people coming to routine clinics. Let's do that. But for the sick people, they need to be a different denominator, and we can do that. And that's probably the way to do it. I don't know what Caroline thinks, but you know, it's they are a different cohort of people.
The green travel plan and our travel plan was not for just urgent care. It was for all of our patients and our staff, and to reduce our carbon footprint, but also reduce congestion as well, wasn't it? Which was something that was affecting the experience and people getting to appointments on time. So there's a combination of things that we're rolling into this because it's an issue we've raised about this particular transfer of service, but it's a valid point for access to all of our services for patients and then staff getting onto site as well. So it's timely that we do something in a year's time, I think.
Yeah.
Thank you. Councillor Simons.
Yeah, thank you, Chair. Yeah, could you consider not charging staff to park? And if you had to increase the public charges, I'm sure most of the public would be happy to have a small increase if it would allow the staff not to pay car parking. I do think, as Nick says, I think everybody needs to make life choices about being a bit more green. I realise this could encourage people not to be so green, but I think that's people's life choices need to be more green.
We don't actually charge staff at the moment for car parking. That's something that we stopped doing during the pandemic to support our staff in the difficult times. So we're not.
Is that going to carry? Is that going to carry on?
My hope is that can carry on. Yes.
Thank you.
Councillor Rush.
Thank you, Chair. I've been on this committee for a very long while now, and ever since the Alma Road drop-in centre closed down and the A&E department at the Peterborough City Hospital was overwhelmed with people going to A&E who shouldn't be there, we have been asking for something at the hospital, a front of house triage, to direct people in the right direction. Been a lot of talk about parking at Peterborough City Hospital, but there's been nobody said anything about the parking at the City Care Centre. The City Care Centre, when it's went before COVID, at 9:30 in the morning, you was having to queue to get parking spaces. So the parking at the City Care Centre is not okay. There's still a problem there. Talking about the buses, do you really want to catch a bus and have to walk from the bus station over Crescent Bridge to the City Care Centre, when in fact you can catch a bus, number 2, number 3, number 4, and now the one from Hampton, and gets dropped off straight at the hospital? Surely that is a better option than having to walk over Crescent Bridge. And as well, in the future, the outpatient at the City Care Centre, outpatient departments are being moved to the City Care Centres, such as the rheumatoid. So that would put extra parking onto the car parking area in the City Care Centre. Booking appointments, surely be able to book appointment is better, so you can turn up at a certain time and be seen, than having to sit in a waiting area with lots of people who are feeling sick, not very well, and you could sit there for I don't know how many hours. Sometimes you have to sit there. So to me, the option of this city care centre to move him to the hospital is the best thing that could happen. Thank you.
Thank you, Councillor Rush. Do we have any more questions? Councillor Bull.
Thank you, Madam Chair. Page 6, paragraph 4.2, sorry, page 18, paragraph 3.6, I should have said. It's good to know that the preferred pharmacy provision model is to be agreed prior to the service transfer. Is there a guarantee that this will happen from the 30th of June onwards? Please. Thank you.
That Caroline, is that you?
I don't think we're planning to change the pharmacy offer. We're planning to do exactly what's offered in the current UTC, where we've got access to the Breton 24-hour pharmacies, my understanding. I don't know, Stacey, if you...
The actor wants to come in here.
Hi, yeah. Can I come on that? So during the daytime, the patients who attend our urgent treatment centre would be able to use our hospital pharmacy. And after that, we've got a Breton Centre pharmacy, which is out of hours, and they should be able to access that, which is 24/7. So it's much easier, while as we know that there's no pharmacy at the City Care Centre at the moment. So it's much easier.
Is it with the idea of the one-stop shop, which I'm all in favour of, because basically what it is, it's a one-stop shop for everyone who's got a health or issue, isn't it? Why aren't you considering a pharmacy on site? Because the Thorpe Road Urgent Treatment Centre used to have a pharmacy. It doesn't currently have one. So why are we being retrograde when we're looking at a pucker top drawer service?
Athar, are you? Jess, did you want to come in?
Yeah, yes, please. And Andrew might want to come in as well, I suspect. So the pharmacy at Thorpe Road never actually opened. There was a sign. It was a bit misleading, I have to say, but it never opened to support the UTC. Out of hours GPs can also do electronic prescribing. So people will be able to access their medicines, and there's always a supply on site for the out of hours GP if there's any issue they need urgent medication. I don't know, Andrew, if you want to add in to that. So there won't be an issue of people being able to either get a prescription that they can pick up nearby, or be given enough medication to see them through the night from the out of hours GP. Do you want to add anything, Andrew?
Yeah, so if we can go back to the totality of the model. We want everybody to ring 111. We have the ability in the 111 integrated urgent care service that if we can deal with their condition remotely, we can send a prescription by electronic prescribing. And for Peterborough, on a Saturday and Sunday night, it's going to be Breton after a certain time, once the Asdas and the places are closed. It isn't 24/7, to be fair. They close at midnight. But you know, that's where we would send them. So but they don't need to come and see us. A lot of them, a lot of patients, they can, in the comfort of their own home, deal with it, go straight to Breton, pick up their drugs, and that's it. The ones that we see at the City Care Centre currently, we don't give them a piece of paper either. We still send it electronically, and they toodle off to Breton from the City Care Centre to get those prescriptions. So if we do 111 first, a lot of it, bear in mind, we will be doing remotely. They won't need to attend a healthcare facility to see a clinician. They'll go straight to the pharmacy. The ones that do turn up at the UTC, as they say, there is a hospital pharmacy during the day, but in the when it closes, I think, so in the evening, it will go to the Breton boots at Breton, which is open till midnight. I think June makes a good point, though. I think it's something I think we should probably look at to the future. It's if we've got a service, is there some wiggle room to extend the opening hours of the pharmacy? I think it's something we ought to look at. As you say, if we're looking at a one-stop shop, that would be sensible. after the hours of midnight, the out of hours service do have a small supply of drugs for essential use that we can give out in the middle of the night. And that will be on site so we will do our own dispensing overnight, and that's what happens currently. We've got injectables and emergency supplies, which we can give out 24/7. So we do have some drugs on site that we can use.
Thank you, Andrew. Joanne, did you want to come in?
Yeah, just to support Andrew really and say exactly the same thing. We are actually looking at pharmacy open till 8 o'clock. We're in discussions to see what we can offer. So while the UTC hours are open, we will have the pharmacy open. We also have, obviously, we will look at people that can just pop across the road to Bretton to get the prescription after 8 o'clock. We'll encourage, but those who do have problems and can't get there or rely on hospital transport to get them home and can't stop for medication, we do have a core set of medication that we can give and dispense from the department as well. So we are looking at all areas to make sure that they do go home with the correct treatment as quickly as possible.
Perfect. Thank you very much, Joanne.
So I have one question. Bretton has been mentioned, but Andrew, and I know we've discussed this previously. I mean, obviously GP surgeries can actually send the prescription to any pharmacy. So does it have to be Bretton, or, you know, if I go along, could I have an Alton Wistow pharmacy instead? Are you able to prescribe to those instead?
Yeah, so the way it works, Kim, is it's called EPS. So in what your day GP does is he'll set you up with a nominated pharmacy for your repeat prescriptions and things. And I think most folks will be familiar with that. What happens in out of hours is not all those pharmacies are open, particularly on the Saturday and the Sunday night. So when you're in out of hours, you select a one-off nomination. And then it searches, it finds out who's open, it searches on your postcode from your own home. And so it will tell me, if I'm ringing someone in Royston, what the nearest pharmacy is to them. It's usually Tesco's up till about 8 o'clock on a Saturday night. So I can send it directly to Royston or Ely or wherever, and then they don't have to come all the way to Cambridge and back, or Peterborough and back, whatever, and they can get it from the thing. So for out of hours, it's absolutely brilliant. And COVID has facilitated that functionality in System 1. So, but yes, if you rang me on a Sunday night and say, well, I don't want to go to Bretton, I'm quite happy to wait till the morning, I can look and say tomorrow morning, search on for 24 hours, it'll tell me who's open tomorrow morning, and I can send it to that pharmacy. So yes, there's a search functionality that allows you to search over various time periods and various postcodes.
That's good to hear, because obviously, you know, some people won't be in need for that medication straight away and are willing to wait until the next day. So it's good to know that it can be directed to their local pharmacy. They don't even need to think about going to Bretton. So that's good.
And if you're on holiday in Cornwall and you tell 111 that you're at home and don't tell them the truth, and you can ring and you get put into us, and I can send it to a pharmacy in Cornwall for you. So it allows all of that. You know, it is really smart.
Yeah, that's good. That's really good. So are there any other questions at all? No more hands. So if there are no further questions, I would like to note the recommendation in the report, which is for the Health Scrutiny Committee to note the progress made by the Urgent Treatment Centre, the UTC Relocation Programme team. So are the committee satisfied that we have scrutinised the report tonight? And if not, obviously, hands raised for any objectors. No, everything's clear, so that's really good. Okay, so that's the end of that report. So thank you to all the officers. It's obviously our last meeting. Caroline, Jess, are you staying with us or are you leaving us now?
I'll stay, but probably put my video off, but I'll be here.
Okay, so to all the other officers that have attended tonight, thank you very much for coming along to our committee. We really appreciate it. Well, I don't need to say safe journey home because you're already at home. So take
this is my surgery. My home doesn't look like this.
You practically live there, Andrew. So.
Well, I didn't want to say earlier, but I live a 10-minute walk from the city care centre, and I drove there in my big 4x4 gas guzzler on Saturday, but I was too embarrassed to fess up to that.
Yeah, shouldn't be admitting that. Okay, well, thank you everybody, and for those that the officers, you're happy to. We're happy for you to leave if you want to leave the meeting now. Thank you all. Okay, so on to agenda item number 6, which is the Cabinet Member for Adult Social Care, Health and Public Health Portfolio Progress Report, including Managing COVID-19 Public Health Update. The COVID-19 Public Health Update, listed as an appendix to the main report, was published as a late report on Friday and is a supplementary document with separate page numbers. This was emailed to committee members on Friday. When referring to this item, please refer to the separate page numbers 1 to 8 in that document. I'd like to welcome Cabinet Member Councillor Wayne Fitzgerald, Cabinet Member for Adult Social Care and Health and Public Health, and Dr. Liz Robin, Director of Public Health. And Liz, I understand we also have Helen Freeman and Val Thomas supporting you as well tonight.
Yes, that's correct. Thank you.
Okay, Wayne, are you presenting your report?
I'll briefly introduce, if I may, Chair. So, yeah, we've got a full complement of public health team tonight who, believe me, I bet they wish they didn't have to be here because they have been working very, very hard. So just before I get into the public health arena, I think my title is probably the longest title in the cabinet or on the council. It takes forever to read it out. But I'd also just like to, while she's online still, say thanks to Caroline, because I also sit on the hospital board, as you know, and I think we've got a meeting tomorrow actually, but they've been doing, in my wider remit of health, as it were, that everybody's been doing a sterling job there. And you know, what has happened in the last year is unprecedented. Who could have envisaged, you know, a year later, here we are. In fact, I was just my last night out was actually a year ago yesterday, when I went to the Key Theatre and I found the ticket in my jacket. That's how few clothes I've had on in the last 12 months, other than my in terms of suits. And yeah, so it reminded me it was a year since we got into this dreadful pandemic, which you know, it's just so many sad stories, but so much to look forward to now as we're rolling out the vaccine, which of course is very much been down to Liz's team and everybody helping her with that. So I'll just give you some highlights, if I may. But basically, the whole council for the last year has been focused on responding to the COVID-19 pandemic. It's a public health emergency. So for the Public Health Directorate and staff, as for many other officers, this has taken much of their time and energy over the last 12 months. But what is clear is that our council directorates, partner organisations, just like the hospital and, you know, anybody to do with healthcare and our care homes and all the care workers, all members of the community have worked extremely well together to protect our most vulnerable residents, and often and repeatedly going above and beyond. And I can't stress that enough. The amount of people within the council that have been redeployed, going above and beyond, and it's the same with everybody connected with the healthcare system in Cambridge, and I'm sure that's true across the country as well. Now, that joint work, all those collaborative people working together, stands us in good stead as we move forward with that vaccination rollout, which, you know, is going remarkably well, and we are really ahead of the game here in terms of you look around the world. So that program, and ultimately we move into the recovery phase of living with COVID, which again, Liz may want to talk about, or you might want to ask the question, because I don't think it's going to go away. I think it is a question of living with it, how we adapt to those changes and mutations and anything like that in the future. Lord knows how we're going to do that, but I'm sure we will. Those relationships and ways of working that have been built during this pandemic can be used in the future, of course, to address serious public health issues such as obesity and healthy weight, because we all know what's happened in terms of those people that may have been a tad overweight or have underlying health conditions. It's affected them more seriously, of course. So the report that I'm bringing you that's before you tonight describes not only our direct response to COVID-19, but also the innovative ways that our public health commission services, such as health visiting, school nursing, drug and alcohol services, have adapted quickly to continue to provide services in all phases of the pandemic. As commissioners, the team have supported them throughout, whilst also continuing to monitor the performance to ensure our residents get the services they need. And we all know that public health grant funding, you've heard me speak about this before, is lower than it should be here in Cambridgeshire, and we are continuing to lobby government for a fairer national allocation. We're still fighting that cause, but obviously everything else has got in the way, but it's not gone away, and we will continue to champion that. But however, from my perspective, I'm confident in the meantime that our public health work across the whole council has been effective through very, very challenging times, and is delivering what the residents need. I'll conclude in the sense that we've all heard, and it's been much national speculation about our numbers in Peterborough particularly. In fact, I've got an interview in the morning to do on Times Radio about it. It's not come down as quick as we would like, but if you go back to the summer, and Liz will remember, we were in, you know, we thought we were kind of in blue heaven because we had little COVID during the summer months compared with other people. So the reverse in our case has happened, and there are many reasons for that, which we've spoken about publicly in terms of the kind of people we have living here, mainly in front-facing jobs, you know, in large single men, for example, sharing HMOs that could all work in the same factory. Or so there's a number of issues going on in Peterborough about why that might be. But I know that the public health team, and again, I will give them a special mention, our comms team, and I know Dr. Kayoum has played some part in dissipating the messages within the Asian community and other mixed communities. I've seen stuff she's done, it's all very positive. And everybody, councillors have been doing their bit to try and spread that message about, you know, hands, face, space, and it's not gone away. But I'm pleased to say it is going down, and we are finally seeing some light at the end of that tunnel. The vaccination is the answer in terms of the long term, but it's not the end game, and we still have to maintain the process of being vigilant and reminding people that they must follow the rules and keep themselves safe, healthy and happy. I think I'll pause there. The report speaks for itself. Anything too technical, I should no doubt get Liz to answer on the basis that she's the one with all the symbols after a name, as are the rest of the team. I'm just merely Mr. Or Councillor, that's it. But there you go. Thank you very much, Chair.
Thank you. Councillor Kayoum.
Thank you, Chair, and thank you, Councillor Fitzgerald, for that mention. It's obviously a privilege to work for the community, and I'd just like to take the opportunity to thank Dr. Robin for her tremendous input, and we are really going to miss everything that you have contributed that has been over and above the call of duty. So a special thank you to you and your team who have been working behind the scenes consistently, and enjoy your very well-deserved retirement. You deserve it. So thank you very much. I think what I'd like to ask is that I often come across patients, and as you very rightly say, we are an industrial city. We have a lot of a working population that can't work from home. And as a result, that could be a contributory factor that obviously you have mentioned within media interviews, like I have as well. It's difficult for a population like that to work from home. And I guess what I'd like to ask is that how far does the council play a role in risk assessing or scrutinising the risk assessment within the workplace? We've got big industrial workplaces like Perkins, for example, and I may have seen patients that are worried that if they don't go off work, they won't be paid. So how far are we influential in asserting those risk assessments from a public health and an authority perspective, please? Thank you.
I do know the answer because I've asked the same question. However, I think I won't answer it. I think one of the public health team can tell you, because again, it will illustrate the kind of work that's going on in the background through the public health professionals. But Liz, or one of you, do you want to pick that up?
I'd like to refer that to Val Thomas, please, who heads our workplace cell.
Oh, see, they've even got a title for it.
Yeah.
Yes, indeed. Yes. We do have a workplace cell, and that's made up of myself and some of my team, but also from all environmental health officers. So we work very closely with the environmental health officers in Peterborough. Over the past year, we've worked with a whole range of those workforces which you've described. And I've seen them really pull out all the stops over the past year. Many of them, of course, there's a continuum, but many of them have worked extremely hard to make their workplaces as safe as possible, and part of that is a risk assessment. And we always, if we think there are any issues, we meet with them. EHs, the environmental health officers, will go down and do a site visit. But I think it's become very challenging as time goes on. I think it's a continuous sort of working with employees around behaviours, not just in the workplace, but obviously outside the workplace as well, because, you know, that spills over into the workplace. But I think that we try as much as possible as to work collaboratively with them. And obviously there are measures that can be taken, and we respond to any issues that people raise with us. And we have a set process which we go through, a whole checklist of things which they have to meet. And we go back and revisit with them and try to be as supportive as possible. But there are big workforces, and I think there's an ongoing challenge. What I'm saying is that, but I think we do have processes in place, and on the whole, work collaboratively with employers, and also I think the workforce as well, because at the end of the day, those are the people that you're really concerned about.
Sure, thank you, Dr. Thomas. I guess sometimes I come across individual cases with patients, and obviously keeping confidentiality. Would you suggest that if I were to raise concerns, the COVID compliance email, which is where I often go to, would be the best? Or would you, could I speak to somebody in public health like yourself if I'm worried about particular? I know you can't comment on individual cases, and that's not what your role is. But just if a concern is raised in a workplace, could that be brought to your attention or the team's attention in that case?
I think we work very closely with the COVID compliance team. So I very often get referrals from the COVID compliance team. And if I need to, I refer back the other way as well. So I think it's a collaborative effort, but I'm more than happy to follow up on anything which I have done, which the team has done over the past year.
Thank you very much. Thank you.
Okay, Councillor Sanford.
Yes, thank you, Madam Chairman. I'd like to endorse all that Councillor Kayam has said about our Director of Public Health, because, you know, she's not only been giving regular reports to the Health Scrutiny Committee, but during the pandemic, she's also been giving regular updates at the group leaders meetings, and also ensuring that information has been going out to all councillors. So I think we've been really fortunate to have her during this crisis. I think it's important that our committee actually actually sort of ask questions about things that are happening at the moment. So I just wanted to ask a question about the controversy over the AstraZeneca vaccine. There seems to be a bit of a difference of opinion because there are a number of European countries have decided to suspend it. Yeah, I was listening earlier today to an interview with somebody from AstraZeneca who was saying there's only been around about 40 instances of these blood clots actually happening across the planet. So I'm not particularly asking for the Director of Public Health to say which of those opinions is true, but the concern that I have is that I've got quite a good friend of mine who is what I would call an anti-vaccine campaigner. And I've just been looking on Facebook, and him and a number of other people are basically putting posts on there saying, oh, look, this proves that all that we were saying about the vaccines is true, that they're not safe. And I just wondered how we can combat the situation where all of these concerns are going to be reinforcing this sort of anti-vaccine propaganda, which, if it takes off and if it becomes widely accepted, is going to fundamentally undermine the fight against the coronavirus.
Liz, are you going to come in?
Yeah, that's fine. Yes, I'm happy to. So yeah, I think that the arguments around vaccine and vaccine hesitancy is a very challenging field. And my reflection on this, actually, Councillor Sanford, was a slightly different one, which is that these people who, we've rolled out lots and lots of doses of vaccine in this country. So our regulators have by far the best understanding of the AstraZeneca vaccine because we've given so many doses. And if, we've got systems to monitor if anything happens. So this country is way ahead in terms of monitoring the AstraZeneca vaccine. And the other countries which have sort of taken some precautionary measures know much less about it because they've given it much less. And the reflection that actually led me to was about the sort of the media that people look at and the concerns that we have about things that are not close to us. And one of the issues with vaccine hesitancy may be that if people are not following the mainstream British media, they're more likely to get quite genuine inputs from other countries that have different views. So I think that sometimes people talk about anti-vax as a very sort of quite a narrow thing, with people being really against vaccination. But I think because this is so new and there are so many different countries in sort of different places around the world in terms of their experience, that quite often it's not a sort of really well-defined anti-vax sentiment. It's more that people are getting their information from different places, and our way of addressing it is often to absolutely give that reassurance, which I'm very confident in from our regulators, because I think we have a really good regulation system which has now a lot more experience than most other countries around the world on what's happening with the vaccines. But also I think that it's about really individual approaches and discussions with people often, because they may be getting their information from different places and they need a really good discussion about the whole information picture. So I think sometimes anti-vax is sort of painted as a bit sort of definite and in a place over there, but actually it's often just about the information sources that people are getting their information from, and very open to that individual clinical debate. So I don't know if that entirely answers your question, but I think that's where it's led my thinking to, in terms of our approach, those individual conversations.
Okay, that's fine.
Okay.
Kim, if I may, just sorry.
Yeah, of course.
From our two penn'orth as our responsibility, we must continue to push that take up of the vaccine is seen to be the responsible and the right thing to do. If you talk about 40 cases out of 17 million across Europe, you know, square peg round hole. And most people, you know, I've heard people saying they're not having the vaccine because they've seen on TikTok that it will harm you. Now, if that's where you're getting your information from, then there's nothing we can do about that. But I think Dr. Robin is right. You know, the credibility here in the UK is much stronger than it is elsewhere in Europe because they're not as informed. So, you know, we have a natural ceiling at the moment. That last 15% is difficult to get in many communities, and we must keep pushing that it's a positive thing to get vaccinated, and that's what I will continue to do. You know, blood clots in 40 people that could have happened naturally, and I'm not a doctor, but that's what I'm hearing from British media, not necessarily from European media.
Okay, thank you. Councillor Hemraj.
Thank you. Talking about the vaccines, can I just praise Caroline Walker and all the trust hard work in vaccinating not just the NHS staff that work in the trust as well as the general public. And I've had both of the Pfizer vaccines and I'm fit and well with it. So I recommend everyone who gets offered the vaccine to actually take it, because it's going to support you as well as others. And thank you, Dr. Liz Robbins, for all your support you've given me over the last three years as being a new councillor. My question is about the rapid testing. Do we have any data on how many people have actually accessed the rapid testing sites? And do we have any data on the workplaces that actually are starting rapid testing, excluding the hospital, because I know they're already doing it, and excluding schools? Thank you.
We do have data on the numbers of people accessing the rapid testing sites, and that is good, and I can circulate it to the committee. I won't quote it here because I haven't got it right in front of me. So
I have, if you want, Liz.
Have you? Excellent. Okay.
Well, I can, like you, I'm always working behind. So as of March the 1st, 7,679 tests were carried out at our 7 rapid testing sites and in workplaces across the county. So it gives you some idea of scale. But that obviously is a couple of weeks because the data takes a little time to come in. So it is being widely used, it seems.
Can I just come back on that question? The workplaces that are accepting the rapid testing, are these the big companies like Perkins, Tesco's, the big warehouses, or is it a bit of mix? Thank you.
That's probably Val.
Yes, it is. It is a bit of a mix. A lot of the bigger companies are doing it themselves before we offered it through our local scheme. But I think more and more are taking it up. But it is a mix, essentially. So we try to support the smaller ones.
Okay, Councillor Bull.
Madam Chair, I'm on page 6, paragraph 4.12. Given Peterborough has leapfrogged Corby and is top of the East region for the R rate, what are these further actions to abate enduring transmission? I know areas like Middlefield, Borges Boulevard, Peterborough Prison remain stubbornly very high. So we know the areas that are of concern in respect of the R rate and possibly catching COVID, but are we actually honing in on these areas to reassure with further measures on messaging on why it's good to be vaccinated, because the more the population is vaccinated, the lower the R rate will be? What are the enduring transmission further actions that you're talking about that will abate the increase that we currently have? And I note that we must be getting slightly worse because we were at one point behind Corby and now we've leapfrogged in the East region. So there's something clearly going wrong somewhere. Thank you.
Who's taking that one?
I'm happy to take it.
Okay.
So yeah, I think Just running through those issues, Councillor Ball. The first is the Middlefield, Borges, Boulevard and Peterborough prison. In terms of the middle super output area, the prison is in Middlefield and Borges Boulevard. So that skews the figures for that area because the prison outbreak has contributed a significant number of cases, and those are all being allocated into that MSOA on the reporting. So it makes the Middlefield Borges Boulevard artificially high in terms of because people read it and think it's community, but obviously there's some in the community, but there's also the prison and they're added together. So I think that's important to be clear on. In terms of the sort of the fall and the enduring transmission, we have been a bit to and fro with Core B. They were above for a while. They've now fallen more quickly. I think there may be some latest figures where it sort of we may alternate a bit as to which is higher. But we are remaining pretty solidly in the top 15 nationally over the past while. So on enduring transmission, we are absolutely taking action in the prison. We're working with Public Health England and the prison to ensure that the outbreak management there is good and the cases are coming down and it's controlled. And lots of asymptomatic testing going on. In the central areas of Peterborough, we do absolutely focus on the messaging. We work with all our communities and make sure we're getting the right messages out through our comms team that are co-produced with communities. We're also making sure that the enforcement is done right and that we have marshal patrols and other enforcement in areas where there are concerns. So we're doing the things that we can do immediately. What's coming out with the enduring transmission, and this is coming out with various areas around the country that have the same phenomenon, in that normally lockdown is a really effective intervention for COVID. So nationally, actually Peterborough was below the national average when we went into lockdown, and it was the same as Cambridgeshire in terms of its case rates. In other areas, the cases have fallen more quickly. And that is, having looked at the areas around the country, and national work is going on this, it does seem to be very much linked with the employment profile in an area. And that's about having people going out to essential jobs where they have to leave their homes. Quite often it's also associated, which is the way that things are, with those jobs being quite low paid and also a lot of agency and 0 hours work. That can be particularly the case in industries like agriculture, packing, distribution, which are very seasonal. You need more workers at some points than others. It's also associated with a lot of people living in a house together in HMOs or houses of multiple occupation. And it's associated with people having to travel to work together. And sometimes that's transport organised by agencies. Sometimes it's just car sharing because not everyone has a car if it's a lower wage industry. So those factors are very much seen together. And that are contributing to enduring transmission in different local authorities around the country. So we have we've really highlighted those issues nationally, and as you know, we had a Cabinet Office COVID-19 field team visit, and we were able to highlight those issues nationally. And we are now working with regional and to some extent national teams to look very hard at these issues and to put forward some proposals that would address some of the root causes of the issues, as well as the things that we can do immediately locally around communities and around enforcement. So we are looking to attract national resources into a pilot proposal to address some of those root causes. And we're working also with Finland that has quite similar rates. I think the latest ones today, just picking up my latest bit of paper, Peterborough's gone down to 125 cases per 100,000. Finland's at 110 cases per 100,000. South Holland is at 131 cases per 100,000. So we've kind of got this geographical area that's wider than Peterborough where we're seeing enduring transmission. And we're working with those other authorities to really highlight our issues and take that forward with some, hopefully some national and regional help and support.
Thank you. That's really comprehensive, and you've answered all the points. I just have a supplementary from that, and given that the prison figures exacerbate our figures, are we confident we're doing sufficient to reduce the R rate? You talked about asymptomatic, there's close proximity within a prison. Are we doing sufficient to drive down that R rate, do you think? Have we got enough resources in there, testing kits, personnel in there to monitor the situation?
So we have a joint response very much with Public Health England, with NHS England that provide the prison healthcare services, and with the prison itself. And we have a regular what's called an incident management team meeting, which is chaired by the Public Health England Prisons lead. And we run through the latest epidemiology, the latest numbers of cases, and we run through a very structured process of all the different issues and all the different resources which are needed. So if there's anything that isn't in place, that should be flagged through the incident management team and escalated very rapidly. So we form part of that response, and we absolutely, if we're asked for support and help, we will put it in. But there are resources obviously coming in through these other routes as well, into prison services. So yes, I'm confident that we're fully involved and that all those actions are being taken, Councillor Bull.
Yeah. And just finally, the Cabinet Office, are they going to bring money to us? I mean, they don't have the capacity to do that, but are they talking to HMT, Her Majesty's Treasury, to ensure that we do have sufficient funds to cope with the outbreaks that we're seeing that are persistent?
I'd be very happy to update the committee as we move forward with our work with the national and regional tier.
Perfect, thank you very much.
Okay, Councillor Burbage.
Thank you, Chair. And I'd like to also add my thanks to Dr. Robin for everything you've done. And I wish you a very long and happy retirement. I'd also like to pay a bit of a tribute as well, if I can, to the vaccination teams. I had my first shot a month ago today, actually, at Orton Wistow, the Halsey chemist, as a frontline worker, and it was absolutely brilliant from start to finish. So well done to those as well. My question is around the schools. Obviously, the schools have now been open for about a week now. I was just wondering whether there's any information on the uptake of the home testing kits that are being issued to students and their families, and whether they've got any success from that at all.
I can certainly give an initial update, and will then hand on to Helen, who may also want to respond because she's our children's commissioning lead. Val is my deputy in Cambridgeshire and leads on the commissioning of the wider public health programmes, just to introduce them fully. But yes, on the children's and the school children and the families, what we have seen is a considerable increase in the number of tests which have been done. In terms of results, we've only got reliable figures for tests taken up to the 10th of March, because there's a bit of a process for making for quality assurance, getting the test results back, making sure we've got all the test results for a date. So at the moment, what we're seeing would basically be infections acquired before the schools reopened. But we are seeing that increase in tests associated with the schools reopening. So that's positive that there is take up. Helen, I don't know if you want to add to that.
Nothing major, just to say that obviously at the moment the testing for children in secondary schools is happening on site in schools, so they're having to have the 3 supervised LFT tests in schools, so most of those will still be happening in schools for the majority of this week, and then the home testing kits will be sent home. So schools are tending to kind of informally, they're reporting that there's been quite good kind of compliance in terms of having those tests in schools, and they're working really hard in terms of getting the information out to families about how the home testing works and what you have to do in terms of reporting those, but we won't really see how that will work in practice for another couple of weeks yet, because that home testing hasn't started.
Okay, and last question from Councillor Kyan.
Thank you very much, Chair. I think that the only concerns I have about the vaccination programme are that, thanks to the tremendous efforts and work of public health and the messages that we've all put out to various ethnic communities, I personally, as a clinician, I've seen an increase in the number of people uptaking the vaccine. The concerns that they have displayed, however, is that sometimes when they go to the national link, they are signposted to an area such as Cambridge where they can't really get to because they may be elderly or they may be frail. Now, as a council authority, do we have any way of pushing sort of an agenda whereby we can meet the requirements of those individuals? As a clinician, I can sit on a chair and say to a patient that, oh, let me just get your name and I will make sure that I add them to our list, but that all depends upon supply, as you very well know. So is there any way that we can try and bridge that gap? And is there an alternative for such patients who can't get to far outreach clinics to have a vaccination done? Thank you.
Jess, did you want to come in there?
Yes, if that's okay. So if somebody receives a letter because they are eligible to book onto the national booking system, there's also a paragraph in there that says if you would prefer, you have choice, and you can go to your local GP vaccination centre. So they can call their GP and ask to be put onto the next available clinic that's vaccinating. So they can do that, and I think there are some discussions about trying to get some of those clinics onto the national booking system, but it's slow progress at the moment.
Sure. Thank you very much, Jess. I think that would be really useful, actually, because I wasn't sure that they had the choice, but we thought we could just pick them up as random.
No, as long as they're eligible and their cohorts, we get technical here, cohorts 1 to 9, they can call their GP practice and they can be booked in if they've had the letter.
Thank you.
I did exactly the same. If you wanted to know, Shabina, my wife had the letter. I called my surgery for her. Don't know why I did it, but and she was directed to an appointment at the Fleet straight away, within 2 days.
Good to know. Thank you.
Good. Okay. So, Jess, you've still got your hand up. Is that just a legacy hand, or? Yeah, that's fine. Okay. So, so that's all the questions. So I would like to note the recommendation of the report, which is for the Health Scrutiny Committee to note and comment on the portfolio holders' performance report. Are the committee satisfied that we have done this? Please indicate by raising your virtual hand if you object. Okay, no hands raised. Okay, so the report then is agreed. So that just remains for me to say thank you to the officers for attending tonight and for presenting the report. And I'm happy for you to leave if you wish to leave. I'm sure there'll be a few of you still staying behind just for the remainder of the meeting. We haven't got much more to go anyway. It's nearly over. On to agenda item number 7, monitoring scrutiny recommendation. Paulina, can I hand over to you?
Yes, thank you, Chair. So this is a standing item for the committee to receive to review any recommendations that have been made by the committee at previous meetings that haven't been completed. There are 1 or 2 from Liz that haven't been updated, and Dr. Robin said that she will provide a verbal update if you require her to. So other than that, it's for the committee to see if they're satisfied with the ones that are complete, or if they wish to continue monitoring any that aren't listed as ongoing at this moment in time. Thank you.
Okay, so nobody has anything to say with regards to that item? No? Okay, so we'll go on to agenda item number 8 and the forward plan of executive decisions. Please note that there is a more recent version of the forward plan, which was published on Friday the 12th of March and was emailed to committee members. And in this version, we will refer to in this meeting. So please refer to page number 1 to 45 of that document. Are there any items on the forward plan that the committee would wish to receive any further information on? Obviously, just a reminder that it is only those items that are listed under the House scrutiny. Councillor Bull?
Thank you. I'm on page 40, item number 8, where it talks about the Healthy Child Programme. It's talking about delegating the commissioning functions from the City Council to Cambs County Council. I understand that's due to happen after the fiscal year ends on the 31st of March. My question is that the NHS staff that are employed on pay points between 2 and 8C will receive a 6.5% increase in salary over a 3-year period. Will this also be subject to the 1% announced in the budget? And how is that going to affect the next 3 years? And why are we delegating to the county rather than staying within the unitary authority? I guess that's a question for Councillor Fitzgerald. Thank you.
Yeah, I think we've lost Councillor Fitzgerald. I'm not quite sure. Paulina, can you just confirm he's? But yes, I know. Sorry, Liz, I know you'll be able to answer that, won't you?
Yes, I can. That's about the agenda for change pay increase, isn't it, Councillor Bull? For the programme. So the delegation to Cambridgeshire County Council to act as the lead commissioner for the Healthy Child Programme is already in place, and that has been running for some time because we were able to deliver very positive benefits from an integrated programme across Cambridgeshire and Peterborough, and also achieve best value by doing that in terms of reduction in overhead costs while maintaining the frontline services. So that delegation is already in place. The issue around the agenda for change pay rise was that when we got the additional public health grant funding at the beginning of this year for Peterborough, that was on condition that we used a significant part of that funding to pay the agenda for change pay rise to providers of public health programmes, which includes CPFT, CCS providing health visiting and school nursing, and also CCS providing our sexual health services. That pay rise had been paid by the Department of Health and Social Care for the first 2 years because it was incompatible with the reductions in the public health grant that we were experiencing at that point. So it had been picked up nationally. With the increase in the public health grant, we were then required to fund those retrospective pay rises over the 3-year period. It doesn't include the new 1%. It is for the pay rises that had already been announced, transferring that burden to us. Because we had that agreement with Cambridgeshire County Council that they would be the lead commissioner of the services, and we'd absolutely defined the money as part of the agreement, we then had to put in a new decision to put in the agenda for change to that agreement. So that's why that decision had to be made. It's just our financial governance, so that additional money going into the contract had to be fully coped with through a cabinet member decision.
Perfectly answered as ever, Dr. Robin, and we shall miss you for your devil in the detail recall. Thank you.
I have a brilliant team. You'll find that when I go. They'll all be able to do it.
Take the praise.
Yeah, definitely. Okay, so it looks like there aren't any other questions from anybody else. So that's the end of that item. So we are coming towards the end of our meeting, and as chair, and this will be my last health scrutiny. I said that last year, and look what happened. Ended up remaining for another year, but we have one big difference in that obviously we have big thank yous to make sure that we have recorded. So first of all, I'd like to thank
Kim, don't go.
Oh, good timing, Councillor Barkham. I knew that'd come at some point. So first, I'd like to thank all committee members. From me, we have asked some probing questions, and I think, you know, we've done Peterborough proud to make sure that we have scrutinised all of the reports that we've had this year, and it has been a difficult year for all of us. So from me to you as committee members, thank you for your contribution. I'd like to thank all the officers over the last year for them preparing and presenting their reports, not just for the last year, but obviously for 2 years now that we've been doing this. I would like personally to thank Paulina and the Democratic Services team for her guidance and unwavering support over the last 2 years. Paulina, you've been a tower of strength to me, and thank you so much for everything that you've done. I really do appreciate it. And last of all, a huge thank you to Liz. We know you're retiring at the end of April, and obviously a lot of the committee members have already said what I was going to say, but we all appreciate everything that you've done for us. I think you've been in Peterborough and looking after our committee since 2015, is that right? So that's sort of six years. So that's a long time. And over that time, you've sort of supported the chair of the health scrutiny, me and obviously previous ones. And I'm sure each one of us want to thank you for everything that you've done, and all the very best. And we hope you enjoy your retirement. So it just goes to say, over to you. What are you going to be doing in your retirement?
I think I'll be getting a lot of sleep for the first month. So.
I think you will. It's been one long year for you, and yeah, I really don't know what we would have done without the support that you've given all of us. So thank you very much.
Well,
and all the very
thank you for being a really excellent committee to work with, and you know, I think that what committees do is so important, asking the right questions, doing the right things, and I would like to thank you for being a really good health scrutiny committee, I have to say. So